Again, feel welcome. We are going to have a number of very seasoned presentations, discussants, and we are going to have question and answer after the presentations. So I want to just give a little background to tuberculosis so that we have a background of why are we talking about TB and why TB. So tuberculosis, as we all know, is a near-born disease. It remains one of the public health challenges globally. In 2024 alone, we lost about 10.3 million lives to tuberculosis. Kenya ranks among the countries that contribute to 80% of the global TB burden. Let me put it into perspective. Globally, we have 30 countries that carry the heaviest burden of TB. And by heaviest burden, I mean about 80% of the global TB burden. And Kenya is among those countries. In the African region, we rank 4th in the burden, starting with South Africa, Nigeria, Ethiopia, and we come there number 4. In 2024 alone, again, Kenya lost about 16,000 lives to TB. Again, putting that into perspective, if we look at the number that we lost to COVID, in 2 years, we lost about 7,000 people in 2 years. But TB claimed about 16,000 lives in just 1 year. In 2 years, that would translate to about 32,000 lives. That means is a real challenge in Kenya. We got about 117,000 new TB infections in the year 2024. So that is basically why we have to talk about TB. But why community-led monitoring? This takes me back to a few years ago when it was reported that there was a stock out of some of the most important commodities in TB response. We got this information from communities, what I would call through grapevine. It was very difficult to get an official report of this stock out. Yet, in advocacy, in programming, data is king. We need to get real-time data. We need to get qualified data. We need to get factual data. But then we do not have that system of getting that real-time data from the communities. And we relied on those calls, random calls, which really we could not verify. And that's why now that's where the CLM comes in. How did community-led monitoring change this situation? How is community-led monitoring helping or informing change of policy, advocacy, and even programming? So today, I want to welcome you to learn what is CLM, how is CLM or community-led monitoring done, how has it impacted TB response, how has it impacted programming, advocacy, and how is it changing policy? So again with me, I have a very informed list of panelists. And to start us off, we are going to have Philip Nyakwana. Philip Nyakwana is a good friend. He's the chair of non-state actors in the Kenya Coordinating Mechanism, what we call KCM. He's also the chair of the CLM Steering Committee. Very happy to have you, Philip. Being a chair, you have all the information about CLM. And finally, he has a very big profile. I'm going to just summarize 3. He's also the co-chair of the Human Rights and Gender Technical Working Group. Philip, you have the floor. Karibu.
Thank you very much, Kibuchi, for such a wonderful introduction. I believe I'm audible enough. And I want to take this opportunity to thank all those who have managed to join this meeting. We are going to have an interactive meeting. The session is going also to give a little bit or to highlight and give the context of CLM in these countries, just as Evelyn has said. So in my overview or putting it to context, I'm going to cover three areas. One is the introduction to CLM. Then we'll also look at the implementation arrangement, that is a framework. In Kenya, we have developed a CLM implementation framework that also goes down to the coordination structure. So broadly, I will look into those areas. Then after that, I believe my other colleagues will go deeper in terms of unpacking further some of these issues. So I know people might begin by asking or wondering, because Evelyn has talked of CLM. So people might be wondering, what is CLM? So we want to first say that CLM is a participatory approach. So it's an approach in which communities take an active role in monitoring. They monitor the implementation, the service delivery, and such kind of things. During their monitoring, they also evaluate these services that we are receiving. Are they of quality? Are they of standard? And such kind of things. And it also aims at improving services. So our CLM, the CLM that we implement, is structured around health, or it's structured to support healthcare. So in the context of healthcare, the CLM enables community members. And when I talk of community members, most of the times or often, those who are directly affected by the specific health issues. And in our regard, most of the time we talk of the TB community, HIV, PLHIV community, those who have suffered malaria, among others. So even in terms of the delivery, the affected communities are also targeted to deliver. They are targeted to systematically collect data on service delivery, quality of the service, because it's not just about collecting the data. As you collect data, you also ascertain or establish whether the service delivery is of high quality, accessibility, and they also collect data in terms of the encountered challenges at the health facilities. So I'm trying to say that the CLM and intervention is implemented at the service delivery point, at the lowest level of service delivery. We have had conversations around CLM and service delivery for a while. Mostly this originated from Global Fund, even though other partners have also been working. Since we started doing the structured CLM implementation, we have some of the key partners that I just want to mention a few of them. One of the key partners in terms of the CLM implementation is Global Fund. So Global Fund has played a very key role in terms of implementation of the CLM in this country. And Global Fund has implemented through AMREF Health Africa in Kenya. There has also been implementation of CLM by Stop TB partnership under the Challenge Facility Fund. They have also played key role. PEFA has also, through UNAIDS, supported the implementation of CLM in this country. There has also been implementation by PEMA Kenya. PEMA is one of the key population organizations or group that also implement CLM. And among others, as I said, I could not be able to mention all of them, but just the key highlight that implementation of CLM has been participatory, and there are quite a number of organizations that have been involved. I am sure my colleagues will deep dive and also unpack some of the areas. But some of the key areas of intervention has mainly focused around training of community members and actors at grassroots level. And their trainings are geared toward collecting data, service delivery, identifying gaps, and also to advocate and to lobby for the improvement of the services that are being delivered. So CLM has also been implemented through structured platforms. So one of the platforms, and I know the most prominent one, is the iMonitor, ATM. Most of us are aware about the iMonitor. It's an app. ATM is not ATM, that one for removing money, but ATM is just AIDS, TB, and malaria. Then we have also had an app called CompCare. CompCare has also been used as an app for implementation or as a tool to implement CLM. There's also the One Impact and the Mabox. So mostly or generally in Kenya, these are some of the tools or the apps that we have used to implement CLM. But as we all know, it involves communities and it cannot be implemented in isolation. So CLM has been implemented through strong collaboration with other CSOs, healthcare providers, communities, and the government. As we are aware, or we may be aware, when you look at the CLM steering committee, where I chair, the composition brings both people from the state and non-state actors. So this also is just to emphasize on the collaborative approach as we implement CLM in this country. And CLM has really helped us in addressing some of the critical barriers to accessing healthcare and improving outcomes to diseases like TB, HIV, and malaria. So I'd indicated earlier that CLM is implemented through a structured approach. Yeah, it's implemented through a structured approach. And this approach, as a country, we cannot implement without having a strategy. So CLM is implemented through a framework. So as a country, as a steering committee, and as stakeholders involved, there's a CLM framework that is used to guide the implementation. So the framework is divided into 3 pillars. So framework has 3 pillars, but those pillars also have different components. So I can easily say that as we implement CLM, we have the 10 steps approach to implementing CLM. And those approach are structured into 3 pillars. So we have, in summary, I will go through some of those pillars. So the first pillar is basically the introductory part of it, and it's called the conceptualization and design of the CLM. So the design and conceptualization is basically around generating demand. How do we create awareness around CLM? How do we foster interest so that people can have a conversation and can appreciate? Then there's also the component of stakeholders engagement. This is where now, as you generate demand, you also involve and work with stakeholders to ensure the collaboration and also buy-in. Then there was the third step, which is basically conceptualization and design. You develop the framework and approach. How do you implement? So you develop the framework for effective implementation of CLM. So once you have developed that, then you also develop the tools. And the tools, as we develop them, it also comes with the issues around capacity building, how you train people around the use of those tools. You also create awareness around, you sensitize people basically on the use of those tools, including the reporting mechanism and such kind of. Then you also have another pillar, pillar 2, which is about the implementation of CLM. And I will broadly talk about this without going into the implementation arrangement. So there's the pillar 2, it's about the implementing CLM activities. And here it involves issues around data collection. And I talked earlier about some of the tools that we use to collect data, like the iMonitor, the CompCare, and such kind of tools that are used to collect data. Then also, as you collect data, there's also the component of analysis, because in the analysis, that is where and when you will know what is the trend, which areas, you look at the geographic, you look at the issues that are coming through the data that has been collected. So during that time, you also identify the gaps, you look at the trend and the challenges. Then after that, you generate solution. Because if you look at this and generate them without generating a solution, then it becomes a serious issue. So you generate a solution based on the issues. So you use the evidence to help you generate solutions. In this process, because most of the time, the players, and I mean, we call them the right holders, people who collect data and people who are affected, most of the time, or sometimes they have solutions, sometimes they don't have solution. So in this process, now they begin to map out and engage the people we call the duty bearers, the people with the solution. So they involve the decision makers. For instance, if it's something that involves, that entails maybe the shortage of drugs, who are the key players that they can work with, they can involve, so that the issue is sorted out. Then once they have involved these people, they have done their advocacy, they have done their lobbying and such kind of, then they monitor the change. After we have done it, what change are we seeing? Is there any change as a result of our work? Then after that, as people say, as they monitor, as they engage the duty bearers, there's the element of advocacy and such kind of things, so that you push. Then the last pillar is about sustainability, because CLM is supposed to improve service delivery, the quality of services that are offered. So these ones are supposed to help us focus on sustainability of CLM. How do we sustain? And we all know if we want to sustain, then we also must put emphasis around areas like community ownership. How do we work with the communities so that they own, that they understand and own the process to ensure the long-term engagement and accountability process. So we also look at areas like political goodwill. In the process of sustainability, how do we work with the political class? How do we work with the key decision makers so that we are able to move? There are also the issue of sustainable financing. So we must develop an investment case, mobilize resources from diverse sources so that we are able to secure long-term financial support, because we are all aware without finances, then we may not be able to move further, we may not be able to achieve, and we may not be able to sustain. So we must also develop and mobilize resources, alongside also the technical support. So there must also be the technical assistance, issues around capacity building. We must strengthen the capacity of CSOs through training, skill transfer, and such, because with capacity, adequate capacity, then we should be able to sustain. Our institutions should be able also to sustain and also to respond to some of the issues that might come. I know right now there are also a lot of conversation around integration, international framework. So as a way of sustainability, the CLM is also aimed at integrating the CLA, because this framework can also not be implemented in isolation. So the CLM, the framework also aims at integrating this. It must be embedded into national strategic plans and such. And maybe for some of you who have been involved, you have seen most of the time we are trying to, how do we look at these issues of CLM, data collection, and such into other government platforms, including the CIDP, so that when we do that, we can be able to enhance or to sustain the response. And as we also work around this, we must create more demand, because without demand, then people, and in our demand, we must look far and wide. How do we engage public sector? How do we engage with the private sector to embrace CLM as a key approach for improving health service delivery? Then before, maybe after that, or as we continue with the process, we also look at the issues of assessment. What is the impact? And then issues of coordination. So because I've mentioned coordination, I just want briefly, maybe for the next 1 minute or 2 minutes, that in our CLM implementation in Kenya, we also have a well-defined the coordination structure. So, and in this mechanism, we operate at various levels. So the structure look at the coordination at the national to community levels and vice versa. So because if it operates from the national to community, that means we can also be able, or we are able also to coordinate from the community to the national level. And at different levels, the key players, we play distinct roles in supporting the framework. But at every level also, they work together to establish effective communication channels. So as we implement the CLM, there are also effective communication channels that for reporting some of these cases and getting feedback, also the issues around setting standard and implementation of policies that are aligned to CLM. So each structure is designed to engage communities, recognizing their central role in CLM, fostering multi-sectoral partnership, and maximizing the impact of CLM activities. So that helps us. So the coordination structure is well available and is present. For those who maybe want to interact, if you have not interacted with that structure, then you can be able to get it at various and at different platforms. So just as I said earlier, in that coordination structure, there's also the data flow, how data flows from the national, from the grassroots, the point of care, that is the health facility, or at the lowest level, at the community level, to the national level, and also the issue of feedback mechanism. So the system is also designed, the data flow system under CLM or for CLM is designed to guide the collection, processing, analysis, and use of health service feedback from community users to inform decision making. So I can say as I wind up that there's a structured pathway for data, ensuring that the information gathered at the community level reach the highest level. They are processed and also incorporated and inform the decision that is being made at different level. And if you engage, and I'm sure even in this call, we have people who are involved as peer monitors, people who collect data and such. They can tell you that in this process, they have gotten some instant feedback and instant response that has helped to improve. But as we are also aware, some might take longer, some might take a shorter period of time, but every time we learn as we move on with this work. So without taking much of the time, in summary, that is the overview of our CLM and the arrangement that we have. But the key thing is that we have structures to guide the implementation of CLM interventions or activities in this country. Thank you very much.
Thank you so much, Philip. I promised we are getting nothing but the best. That was quite a very comprehensive overview from Philip. Philip, you have really been elaborate on an overview of the CLM. And if you must forget anything that Philip has said, don't forget these ones. One, he has mentioned that we have a framework for community-led monitoring that guides implementation of the CLM. He has mentioned about 3 apps that we use for CLM. That is One Impact, iMonitor, ComCare. These are just examples. And Philip, if you allow me to add, manual ones like suggestion boxes is also a method of CLM. Yeah, he also mentioned about the need for having an integrated approach in CLM such that we are not just focusing on one disease area, but we are doing comprehensive CLM for health in general. And thank you also for bringing the fact that we have coordinating mechanisms from the national level to, very presently, community levels. It's a very, very important that communities are involved in this. And one more thing he has reminded us is that ATM is not automated teller machine, but AIDS, TB, and malaria. Thank you so much, Philip. Yes, and a few
Thank you.
comments
Thank
from
you so much, Evelyn.
participants. Yeah, we have Anthony saying, Yakwana, you're dissecting CLM in a community-friendly language. Thank you so much. Emily, you're saying very right, very right. Sustainable financing is a challenge. Yeah, thank you, Philip. You also mentioned that on the need to have sustainable mechanisms and also do resource mobilization to sustain CLM. So thank you, Philip. Just stay on board. I'm sure there are so many questions that may come up. Participants, kindly keep posting the questions that you may be having to make it easier when we get to answer the questions. To ask questions. So next, allow me to usher in our second presenter. Our second presenter is a very seasoned programmer in public health. His name is James Ochieng. James Ochieng is a program associate in community systems strengthening in AMREF. He's experienced a list of areas that he's experienced in. One, stakeholder management, capacity building, research, implementing research findings. He also focuses on strengthening community-led monitoring, engaging civil society organizations, and also in strengthening health systems. James, you're very welcome. You have the floor.
Thank you, Evelyn, for the introduction. So allow me to share my screen. Please confirm that you can see my screen.
Very clear.
Yeah, so thank you, Evelyn. And the beauty of not being the first person in any conversation is that part of the work can be done for you. So majority or part of my presentation, Philip has already tackled. However, the only difference is that in terms of the framework, I will be showing us using a diagram of the different stages that we have, as well as other more details. So in terms of the outline of this presentation, there's some bit of definition, and Philip has given a definition in the context of CLM. When we talk of community, we really don't refer to geographical boundaries, so we'll look into that. Then I will also be tackling where did we begin with CLM in Kenya? How did it begin and when? And maybe where are we currently in terms of coverage? Then why CLM? We'll be diving into the importance of having CLM. Then into details, as Philip had mentioned, we have a number of tools that are being used in implementing CLM, but in the context of Kenya, iMonitor was adopted so as a tool to use in the implementation of CLM. So I will be giving a bit of information about CLM. Then over time, the data has been coming through the iMonitor, being reported by the service, those who are receiving services, and I will be diving into some of the data that we've analyzed that are TB related, as well as a bit of challenges and way forward. So the definition in terms of definition of CLM, basically here we are referring to, when we talk of the word community, that keywords that we need to understand for us to have a good understanding of CLM. That's called community-led monitoring. First, we have to understand what is community in the context of CLM. Secondly, we have to understand the meaning of community-led in the context of CLM. And finally, now a combination of these two words, what does it result into? So in terms of community, here we are referring to people living with or affected by diseases. So if we have people who are, for example, the PL-HIV community, we will refer those people as a community. If we have people suffering maybe from cancer, that group of people we can call them a community. And in CLM, given the support that we are receiving from Global Fund, major focus has been around those who have been affected by HIV, TB, and malaria. And we also look at other marginalized groups, and this could be as a result of maybe gender or sexual orientation and the rest. And in terms of community-led, it basically means community taking leadership in designing the intervention, as well as looking deep into its implementation of various interventions and disseminating of the CLM. So we know over time, in the past days or in the olden days, some of these interventions were drafted in office. Maybe somebody in Nairobi sitting and maybe thinking people in Suba might need this particular intervention. And in some instances, such interventions have failed. So what community-led monitoring is bringing up is the active participation of the communities in terms of coming up with the interventions, right from the conceptualization of these interventions all the way to the implementation, as well as the monitoring. So combining the first word, that's community, and community-led, which now give us community-led monitoring, we basically mean is a process where communities take lead in monitoring health services, as they're the people who receive these services, and they participate in the designing of these services, as well as the implementation. And of importance is that they also participate in tracking the quality of the healthcare services that they get. And along the way, if there are areas that needs improvement, then they participate in advocating for change by engaging the duty bearers and trying to improve the accountabilities of the duty bearers. So in terms of history of CLM in Kenya, and as Philip had alluded earlier, currently the CLM in Kenya has been majorly supported by resources from Global Fund. And it began with a pilot that was done in the Grand Circle that began in July 2018 to June 2021. And this was a pilot phase. And the pilot was conducted in 3 counties, that is Homa Bay, Vihiga, and Kwale. And it is good to note that not the whole counties were covered with the pilot. We only chose 1 sub-county in each of the 3 counties. So given the outcomes that were realized during this piloting phase, it informed the scale up. Like the good results that we got based on the piloting informed the upscaling of CLM, and that's in the new Grand Circle of 2021, July to June 2025, what is commonly known as NFM3, we upscaled, informed by the findings of the pilot phase. So we scaled up to 15 counties, covering now the entire of these counties. So these are the counties where we started in terms of full implementation of CLM. We have Homa Bay, Busia, Kakamega, Kisii, Kisumu, Kitui, Kwale, Migori, Mombasa, Nairobi, Siaya, Taita Taveta, Turkana, and finally Uasin Gishu. Again, as I will be showing as some of the good results that we realized in the previous grant, when we were doing the grant for the current grant, that's the grant that began last year. Now we had a justification why we need to scale up further, and additional 10 counties have been added in the current grant, courtesy of the good work or the outcomes that we realized in the previous grants. So we did introduce 10 new counties. That means out of the 47 counties that we have in Kenya, we have active presence in 25 counties at the moment. But it is good to note that the implementation of CLM is taking place across the country. What I mean by this 25 counties where we have direct support in terms of those who are supporting us in creating demand, those are the peer monitors. And also sensitization of the general community about the iMonitor. So the new counties that we have are Kiambu, Meru, Nakuru, Machakos, Murang'a, Kericho, Makueni, Narok, Kilifi, and finally Kajiado. It is our hope that by the end of this grant, we will also get some good results that, if possible, then in the coming cycle of the grant, that's GC8, then we may be able to scale, if possible, to all the 47 counties. And Philip had already alluded to this particular framework. The only difference there is that this one is in a pictorial form. So we have actually 4 pillars. One was introduced not very long ago. That's the pillar on pandemic prevention, preparedness, and response. So I want to take us through this particular cycle, what takes place at each step, of which I will not dive so much into it because basically what Philip had highlighted earlier. So we have this conceptualization phase. This is pillar 1, running from 1 here up to 4. So this is the conceptualization phase where we want to majorly trying to put up systems for CLM, and we start by creating demand. And in demand creation is just basically creating awareness about CLM and the various tools that we have. And for you to create demand, you also have to involve the various stakeholders. For example, the leadership of the various constituencies, the various communities, in just also getting their views and understanding as well as their input, because they are very key in the success of the CLM implementation. Then at some point, after you've engaged the stakeholders, we do conceptualization and design. This is basically how then do we want to implement this CLM. This will be followed by the development of the tools. Now, tools here are the various ways of implementing CLM. This particular summary of the framework is what I can say, a guidance for any partner that want to implement CLM using whichever tool. And the tools have been mentioned. We have the iMonitor, we have the ComCare, we have the Mabox, and not also forgetting the government ways of doing the community-led monitoring, for example, using the community scorecard, the suggestion boxes that we have at the facilities. Yeah, so then we have pillar 2, which runs from number 5 here all the way to number 10. So this pillar 2 is basically now we are doing the implementation. We've designed how we want our CLM to run. We've also developed the tools. Tools here, if you've chosen to use iMonitor, now maybe already you've developed the questionnaire that you want to use with the various variables of your interest. So once the tool is ready, up next, we now dive into pillar 2, which involve implementation. And under implementation, the first activity is data collection. So data collection, for example, when we are using iMonitor, which is freely available in the Play Store, then everybody, the general public, can just download the data and give their feedback. And the feedback here does not mean complaints alone. It also involves feedback. like compliments based on the experiences that somebody has had when they visited health facility. Once we've collected these our data, at some point we will do advocacy, but once we have our data, we need to do analysis of this data to see what is the data telling us. These analyses will be very important when we are doing the advocacy for various issues that we think are not working. So we analyze this data with the aim of generating a solution. So as the service users, we are best placed to suggest solution of various challenges that we are experiencing as a community. So generating, we are not just collecting this data just to point out the gaps that are there in the service delivery, but we are also aiming at being part of the solution. So we are trying to generate the solution based on the findings of this data analysis. And the analysis helps us to know the trends. Maybe over the past 2 months, there has not been commodities in maybe a facility. So once we have this proposed solution, or once we have the proposed solution, now we aim at engaging the duty bearers. So duty bearers here, if we are at the county level, we are talking of maybe the governor, the CC health, depending on the issues that have come up. And some of the issues that are coming up from the analysis that we have, for example, might need also the intervention of the county assemblies. For example, if we say a facility does not have adequate toilets, we know for a toilet to be constructed by the county, there must be appropriation of some resources at some point in time in the budget making process. So some of the issues we have here will now engage the duty bearers. Depending the type of duty bearers to be engaged will be informed by the issues that have come up. So once we've engaged the duty bearers, we've told them this facility does not maybe have a toilet. Our expectation is they need to act. The duty bearers need to act with an aim of trying to resolve the issue that has been raised. So we will monitor change, the communities will monitor change, and in the event there is no change, now there's a bit of doing an advocacy. And this advocacy is not that advocacy where we have to carry matawi in the streets of haki yetu, but it is an advocacy that is informed by data and very structured. And it could even include the aspect of having dialogues, doing memos to different offices within the county. And then the process continue. Once we advocate for change, if there is no change, now advocacy and the process continue. When we come to this side, where my cursor is, this is basically the third pillar, the aspect of sustainability. We know currently CLM is majorly funded by the Global Fund, and we know what happened last year with the new regime in the US. So there is need for us to really ensure that our CLM is sustainable, so that even if the donor pulls out in terms of support, then we are still able to maintain the CLM that we are implementing. And the sustainability here involves a number of things, which includes community ownership. The community should own the whole process of CLM. They should feel being involved in the development of the interventions. Then we have the political goodwill. This is very, very important. Remember, at some point we are saying we may want the government or to integrate CLM into the government structures. And some of the structures, for example, ICHIS or KIS, these ones there's some allocations that are normally there. So we are trying to have good political goodwill, both at the county and at the national level, such that if maybe appropriation of resources is being done for the health interventions, then even CLM is considered as an intervention area, and maybe some resources is allocated for it. And there's still also the aspect of technical assistance. We know technology is also advancing, and each and every point in time, we might need to capacity build the community health actors as well as the community general. For example, the number of improvements that we've done in the current iMonitor, and we had to take the peer monitors through these changes to enable them effectively disseminate the same to the general population. And I've talked about the need for integration of CLM into other national frameworks such as the ICHIS and the KHIS. And it is also good to know that with the CLM, we are not replacing the routine monitoring by the national government, but it is just a complementary mechanism for some of the information that maybe the normal monitoring processes by the government or MOH may not get the information that might not be picked by the routine monitoring processes. Then the aspect of coordination, Philip had talked about it, and I will dive into it further. So the last pillar, which was introduced not very long ago, is a pillar on pandemic prevention, preparedness, and response. And this one was informed by the happening that was brought about by COVID. We all know how COVID disrupted us. So then the thought process here is, can we use CLM also to help in pandemic preparedness? The data that is coming up from the iMonitor or from whichever CLM tool that is being used to help us do a bit of predicting some of the possible pandemics. And a good example was sometimes back last year, we had a stock out of BCG vaccines. And one of the platforms where the issue was reported was on iMonitor. And once that came in our radar during our routine analysis, it was picked up and in consultation with other organization, especially HENET, they were able to bring this to the media. And I think at that point, even the government owned up that indeed we have some shortages of BCG vaccine at that time. So there is need, we are trying to have CLM also in trying to predict some future occurrences. For example, if we have stockouts of commodities, we can just analyze the data and see the patterns. How often is the stockout of these commodities in a given facility? And this is very important because we are having real-time feedback. The super users who are the duty bearers at the counties are able to have access to the back end of the data, and they're able to see what is happening. So we also mean strengthening the community trust and the need for risk communication. During COVID, as an example, the aspect of communication at some point was not very clear. And I think this is what got many people confused along the way. So through CLM, we can be able to have a very structured pandemic preparedness and risk communication to the general public. And this would help inform how we are responding to these pandemics whenever they arise. So why CLM? Bit of it I had mentioned. CLM is important because it enhances engagement of the communities, not only in the consumption of the services, but right from the designing of the various health interventions all the way to monitoring of these services. The other reason why it is important, it helps us in identifying the gaps in health service and help create demand by engaging the duty bearer. So once we have the data that is flowing through, that is informed by CLM, then we are able to engage the duty bearers by showing them the gaps that is coming up and experiences of the various community as they receive care. Then there's that aspect of enhancing accountability. Once the service the duty bearers are aware that at least there's some platform through CLM that the communities are able to give feedback, they will be more accountable to the people or to the community. So they will try and make decisions that somehow are beneficial to the general population or the different communities that we have. Then we have the aspect of human rights. CLM tries to promote human rights in public health programming. Then we have enhancement of quality of data. I've said that CLM is not replacing the routine monitoring of the monitoring procedures of the MOH or the government, but instead it complements. And that's why we are looking at a point in time when we will be able to integrate CLM with other non-government data streams like the ICHIS. Then there is the aspect of providing realistic ideas. Service users are very much aware of possible solutions to their problems. So CLM, this data help inform when we have engagement between service users and the duty bearers, the service users are able to propose some of the most realistic solutions to the challenges that they're experiencing. So in terms of tools that we have, the iMonitor, which I've mentioned, that this is what was chosen to be the tool for CLM in Kenya, and it is very available in the Play Store and App Store free. Everybody can just download and register. And when you register, you can either register as a community. So this is just the general user. You register as a community or as a super user. So just to mention something on super users, we have the duty bearers that we've sensitized on CLM across the 25 CLM counties, and we've given them some access to the back end of the system, and they're able to see the issues that are being raised. So their main role is to support in addressing the issues that are being raised from their communities, as well as also seeing the compliments. So it is not issues like complaints alone, but we have compliments as well. So you can basically scan this QR code, then you will be able to download it will take you to the link to Play Store, and you will be able to download the iMonitor. And in the spirit of embracing technology, there is a new development that we've introduced. It will go out soon on use of WhatsApp. So if you really maybe if you don't want to download the app, or maybe your phone storage is low, we have the option of WhatsApp chatbot, which we are launching soon. It is already finalized. We've already planned some meeting with our implementing partners to take them through, and it will be very simple. So what you will do, anybody just need to save this number on their phone book and start by just saying hi. Once you initiate a conversation starting with hi, then you will be able to have the whole process of how you would otherwise report through the app. That will now, the provision to use this particular WhatsApp has been enabled. So in terms of within the iMonitor, we have different interfaces depending on the user level and access. So we have the public dashboard. So public dashboard is generally available to the general public, and it does not need you to install maybe the WhatsApp application or anything. This is the link, which at the end also have included a QR code. So once you click this link, you will be able to see. I don't know if it will be able to move. Let's see. Are you able to see the screen still? Somebody confirm?
Yes,
Yes,
we can
yes,
still
yes.
see it, yeah.
Yes, so this is where the link is available to the general public, so you can just come and see the issues that have been raised. And it is also good to mention that previously the iMonitor was with the developer where our data was hosted, but currently the data was transferred, the iMonitor was transferred, and it is available at the AMREF servers, though at some point in time when community will advise where whichever community organization will host it. So the public dashboard is available for everybody. You can just come filter anything that you need. So once you filter, you would, based on whatever you need, you can go through the inpatient, outpatient, HIV or TB. For example, if we click TB, there are a number of things that we can see, the issues that are coming up, testing issues, issues of high cost, and yeah, so this one is very available to everybody available to the general public. So you can just use it. You will see the aggregate numbers, not the nitty-gritties of the issues that have been raised. So, okay. Yeah, back to my presentation. So I have a QR code that I've also included. You will be able to, you can just scan to get the link to the public dashboard. Okay, just a minute. Okay. Yes, this is where we are. So the super user dashboard, I've mentioned the public dashboard. So we also have the super users dashboard. And this one is where the interface where the duty bearers, people like the in charges, the sub-county CTLCs, the CTLCs are able to look at view the data that is the issues that are being raised from their various facilities. And we have enhanced this. Previously, we had fewer super users, but currently we've tried to increase the number to include even the facility in charges. So then they're able to sort out some of the issues at a lower level, at the facility level, as opposed to having them escalated. And of course, the bit of escalation is still there for the issues that are beyond them. So the super users can use a desktop once they have the link to resolve the issues that have been raised. They can well as use the laptop. And recently, we also enabled them to use their mobile phones just to do the resolution of the issues. So some of the TB-related issues that have come up from the iMonitor, and I mentioned that we have the new system. The new system is the one that we purchased and is currently at the AMREF servers. So this is just a bit of summary. We started using it in October last year. So this is data up to February, that's last month. We have compliments that is also coming around TB, which were around 97. However, the complaints did outweigh. This is general, and the interest is on areas about TB. We had 13 compliments and 369 complaints that came up. So some of the complaints were on prevention and testing and diagnostics, as well as care and treatment. And in terms of complaints in regards to prevention commodities, we have some people reporting on affordability as well as availability of some of these drugs in some counties. And the main reason why this seems to be coming up, not all facilities are treatment sites. So somebody might visit a facility, but there is no drug at that particular facility. So then it means there is need for referral. So some of the issues on testing that is coming up, two people mentioned the issue of high cost of testing. And we also had some people saying that they did not get TB testing services, and that's a total of 36 people. Some people also fear getting tested. And so these are basically a bit of the issues on testing. Then we had also issues on waiting time, where the receivers of the services are complaining of a long waiting time to see the healthcare providers. That's long queues, majorly around long queues, and also long waiting times for medical refill or supply. Then lack of information about expected waiting time. So this one help, for example, we know each facility should have a service charter. So where CLM will come in, if we have long waiting time, for example, what does the service charter for that facility say about the duration somebody expects to take, maybe when they come to for a refill? So then if it is going beyond the time indicated in their service charter, there might be now need for a bit of advocacy on that. So there's also the issue of inconsistent appointment scheduling and long waiting time for treatment initiation after diagnosis. So we also have compliments that have come up, and some of them include facility serving clients very well, especially keeping time. Also do follow up on their clients. So these are specific to TB compliments that we managed to analyze. Somebody also said received TB drugs on time without sweating. Two issues raised by facility being escalated faster than previously. So like I mentioned previously, we had fewer people who had access to resolve issues like the super users. But currently, we tried and brought it down and have even the facility in charges being able to address their own issues that are coming up before they can escalate any that needs to be escalated to higher levels. So they are also talking of cooperation and supply of supplements, as well as complement on good service. So we have other more details on prevention. If you look at prevention, again, these are complaints. So these are now the nitty-gritties of the issues that have come up, which I've given in the previous slide. The previous slide gave the summary. So these are now the nitty-gritties around those issues that have been raised. So I might not need to go through all of them, but I might just pick a few. Long queues and delays at the health facilities when accessing TB services or medical refill. So these are now the give more information that have been provided by whoever gave this particular feedback. So these are still more on testing. We have lack of TB testing services at facilities where a patient could not receive TB testing, and the facilities they visited. So this is where I think, because not all facilities are TB treatment sites. So maybe somebody visits a facility and it is not a treatment site, then it means they have to be referred to the TB treatment site. And there's also non-functional diagnostic equipment, for example, broken X-ray. So this was reported. And we are able to even go into the details of this to know these facilities when interacting with the data. It is only that not all that summary is possible to put in a presentation. So yeah, so these are some more details about the issues that are coming up, and all these key issues are being looked at by the healthcare workers at the facility level, since we have given them the rights to look at the data that is coming up through the iMonitor. So I mentioned that most of the scaling up have always been informed by some good findings that have come up right from the initial stage in where we did the piloting. The good outcomes is what informed now the scale up to 15 counties in the previous grant, and also what we had, the good outcomes in the grant that ended last year, June, is what now informed what we have. So just to rush us through some of the outcomes that we have. And this one is with regards to the new system that we began using last year. So we can see we had a complaint from the general communities led by the peer monitors in this facility. This is Bamburi Dispensary. Initially, it was looking like this, dirt everywhere, and the peer monitors and attached to these facilities managed to do some advocacy on the need to have this place cleaned up. And we've seen what maybe this kind of waste have done in terms of blocking even the runway for run surface water in different towns. So there was an advocacy that was done. The place was cleaned up, and now we have it well beautified with the different flowers and trees here. So this one is very recent. It has not taken very long. And we also have a dispensary sub-county. This Kangeta, I think, should be in Meru, where they did not have a disability-friendly toilet, and the team there did advocacy, and finally, few weeks back, or around 1 month or so, a disability-friendly toilet was constructed, and this is what we can see in this picture. So we have also a case in Ngonga dispensary. So this is in Awendo sub-county. Initially, the facility, this photo up here, like the paint had gone down, like it was very rusted, and the team there did advocacy. We had now the facility repainted, and the water tank that was lying down there was also put up. Now they're able to tap the rainwaters. Yeah, so in the previous grant, these are some of the outcomes that we had. We had facility improvement and renovation of infrastructure. So we had a case in Siaya where in this particular dispensary, Mulaha, we had a new toilet new toilet block that was done courtesy of the advocacy done by the citizen advocates that we had at that time and the peer monitors. And in Vihiga, we also had the engagement between the peer monitors that we had and the community, which led to coming up with the Social Justice Center to improve responsiveness.
Sorry to cut you, James. Try to summarize because we're running out of time. Thank you.
Thank you. So I think basically these are just examples. I might not need to dwell into them, but this is what actually informed the scale up into the new 10 counties that we have. And these are just a continuation. So there are a bit of challenges that we are experiencing, and the example is low coverage, and we are trying to reach to as many community members as possible to improve coverage. Then the other challenge is the resolution of the issues, which is taking very long. And to resolve this, we have expanded the super user level so that we have even the facility in charges being able to resolve these issues. And there had been some bit of downtimes because of the upgrading that we are doing. So the system upgrade we've now completed, and the few hitches that currently being experienced will be able to have them addressed. Yeah, so basically that's, and thank you. Over to you, Evelyn. Thank you.
Thank you so much, James. Sorry that I had to cut you to request you to summarize because of time. Yeah, we're just from listening to one of the gurus of CLM in Kenya. And that has been very comprehensive, what I would call the ABCs of CLM. I am very sure if you didn't understand CLM by the end of this, you now have a better grasp of what is CLM. James, just a few things I have picked that we should not forget. First of all, if you have not already downloaded the iMonitor app on your phone, this is going to be a practical lesson. Kindly download it and learn more practically from it. James, you have also made this clarification that is not just about reporting problems. It's also complementing where work has been done well. You have also said we should always suggest solutions. Sometimes people know what the problem is. They're looking for somebody who can come with a suggestion. Can we do this? Can we do that? That is the essence of all this CLM. Yeah, you said does not inform the advocacy of Kubeba Matawi. For those who know me, you know I feel attacked. That's on a light note. I like carrying Matawi. Yeah, there was a request if we can share the slides, and I believe that can be is possible. And finally, there is a request that James has made that we have done 25 counties, but the target is to reach to 47 counties. So if we are going into the writing for GC8s, kindly make a plea that we have CLM expanded to the 47 counties. And there's one comment that I said, oh, I'm very, very excited that we can see the outcomes of CLM. Thank you so much. That is one of the things that I'm also excited about, that it's not just a tool. It's a tool that shows impact, that has influenced policy, that has influenced change. And that's a difference that CLM brings. So we want to move into our final presenter or panelists. And yeah, I need to give her a proper introduction. So Brenda Wachira is a youth. She's a TB champion, very passionate about community strengthening, especially for TB response. She's one of the implementers of CLM, and she sits in the board of one of the TB organizations. And Brenda believes that ending TB requires meaningful community leadership and that the experience of those most affected remains at the center of TB response. Brenda, welcome. And I'm going to request you to just try and be summarized because we have really run out of time. Thank you, Karibu.
Okay, thank you so much, Evelyn. I believe I'm audible enough. So thank you as well to my fellow panelists, Philip and James. I believe they've covered quite a lot. So from a community perspective, Philip had said that CLM is a participatory approach, but as a peer monitor, I believe that in order to achieve this, CLM really starts with something simple, and it's all about listening. It's about going into communities, understanding what people are actually experiencing when it comes to accessing services. Because sometimes when we look at reports, things may look okay on paper. We usually say that, we always say this, that we have good documents, good papers, but things are actually different in the ground. So when you spend time in the community, talking to patients, talking to people, and even engaging health workers, you begin to understand the situation more deeply. You hear the challenges people are facing, but you also hear what is working well. Through CLM, we are able to create these spaces where communities can share their experiences openly. But the important thing is that we don't just leave these conversations in the community. We are able to document the feedback using tools like the iMonitor, which James and Philip have explained it perfectly, so that what communities are saying is captured and can reach the people responsible for improving these services. And when we keep having these conversations in the community and documenting the feedback, we start to, James had mentioned the public dashboard. And if you have the app, you know that you can be able to filter the issues that have been reported in the iMonitor. So in some cases, you realize that some issues keep coming up again and again and again. And I'd like to give an example of where I'm supporting CLM in Mathare sub-county, Nairobi. While engaging patients there and also talking to the clinician in the certain hospital, we started seeing a pattern, and a number of people, especially men who are on TB treatment, were struggling to adhere to their medication. So naturally, we started to asking ourselves what is really causing this. And as we looked at it more, we realized that the alcohol use in that area was a huge problem. So together with the environment some of these patients live in was making it difficult for them to stay consistent to their treatment. And this is where CLM becomes very important, because once we notice these kind of issues, we were able to document them and bring them forward so that they can be addressed. And together with a few people, we were able to write to the area chief explaining what we were seeing and how it was affecting treatment and adherence among patients. There are still conversations going on around that. So nothing has, we don't have the clear conclusion to that, but that is what a CLM really looks like in practice. It helps us move from just noticing challenges to actually raising them and working with communities and leaders to find actual solutions. Another important part of our work is creating community awareness, and James had mentioned that as we engage people in the community, we also realize that many still do not understand TB, the symptoms, especially in those areas, the symptoms, drug adherence, and all that. So as TB champions and as peer monitors, we spend time sharing information with communities, encouraging people to seek care early and support patients to stay on treatment. So also, I believe that CLM helps keep everyone accountable, because we are able to document both the challenges communities are facing, but also the successes and the progress that is happening. And in the iMonitor app, there's not only the complaint side. If you have any complaints, you can also document it as well, and that helps us track and keep everyone accountable. So, and when communities are share their recommendations there in the iMonitor, those recommendations come directly from the people experiencing the issue. So the solutions we talk about are not just coming from outside. They're solutions that are coming from the people. And when the communities see that their voices are being heard and actually acted on, they feel more involved. And more confident in the health system and the services that they are getting. So for me, CLM is really about making sure that communities are not just recipients of service, but active participants in shaping how these services work. Because when communities are involved, even the services become more responsive, more accountable, and more people-centered. Thank you. That was my time. If you have any questions, feel free to ask. Back to you, Evelyn.
Yeah, let me summarize with one sentence. Communities are not just recipients of services, they are active participants. Brenda, that's a very good way of summarizing that. And you've also mentioned about the fact that CLM improves accountability. When you know that it's somebody who is checking on you, then you're likely to be to act more in a way that you're accountable. And I like the example of how you're able to know that one of the challenges of adherence was alcohol, and all this was reported through CLM. So we have had from three levels of actors in CLM. One at the governance level, that's Philip Nyakwana, a seasoned programmer, that's James, and an actual implementer, Brenda Washira. That has been quite like it's a whole cycle of CLM implementation. Now, we are so running out of time, but we still have some few minutes for a few questions. And before I ask for questions, I have picked quite a few. One of them says some facilities do not have cough zones within their compound. Hey, CLM has started being active just right now here. So, Quinta, maybe you could just download the iMonitor and put that one there. There's another one who says, so some super users do not respond to issues. What a challenge. Yeah, I hope someone is going to respond to that. Anyway, I can take about maybe 3 quick questions if I can see any quick hands. Any hands? We can take 3 quick questions. I can't see any hand up. Is there anyone who can see the hand? I can't see. Okay, fine. There's Ronald Ombori. Yeah, let me first give a chance to Ronald, and then I'll read a few more that so I can see there are 3 more. There's Ronald first. Say your question and kindly let's summarize our questions in the interest of time. Ronald. Ronald, do you have the floor?
Just unmute him or her.
Yeah, unmute him. Okay, if he can't be able to speak, I am going to pick another one. Kennedy Othiambo Otina, then Rosemary Kasiba. Kennedy. Christine, kindly help me to unmute this.
Eric, you're there. You can help unmute.
Unmute Ronald, unmute Kennedy, Rosemary, and Christabel. We'll just have those 4.
Eric, you can hear us.
Yeah, Ronald is saying he's not able to speak. Okay. Okay, I can be reading some of the comments. Insightful presentation, educative presentation, very motivating. As I wait for the administrator to be able to unmute. Yeah, this presentation is quite inspiring since we started CLM advocacy. It's working in our communities. Ronald, I had seen your question saying that iMonitor does not work where you are in Migori. We actually request that for the purposes of equity and equality principle, kindly, my CLM, CLM being 47 counties. Remember I said that is the goal of AMREF in the GC8, if we can get funds to do that. I am Jemima Mai, representative of New. Oh, it's not a question. Okay, are we able to unmute any of them?
Yeah, I've called Eric. Eric, you can hear us. You can be able to unmute. You can start with Ronald.
Yes, they can unmute.
Okay, Ronald, are you able to unmute yourself?
Yes, now I can be able to unmute myself, please. Thank you for that.
And kindly summarize your question.
I'm concerned, and a very genuine concern, please. We have been talking of drug interrupters, and one of the key issues that makes people to be drug interrupters is this alcohol. What mechanism that Akina Eli Kinyakwana has to ask those who raise the concern so that we can be able to liaise with the chiefs and plus the Nyumba Kumi so that we can be able to civic educate these people? Because we usually use our own means to go to the communities, everything. We're not funded by anybody now that there was a stop work order and our people are still suffering. That was the question, please.
Thank you. Philip, you'll answer that. Rosemary Kasiba?
Okay, thank you so much, Evelyn. Mine goes again to Philip and Christine, now that they're here. I know we've had conversations about the steering committee that is led by Philip as the chair. Listening to the presentations today, I must acknowledge that after developing the framework and now that it's been rolled out, it's key that we may be able to meet, convene again, and just get to understand so far when the rolling out is happening. Do we have any challenges, or how can we be able to address this at the national level, also at the county level and the community level, so that it's not just left to the peer monitors and the CLM implementers, but the people who came up with the framework to be able to look at it and see if it's working and if we have any gaps and how we can address the same. We are talking of, that's the first concern. The second concern is about the GC8. We have talked about data being key component in the GC8 development, and I'm glad that we have the CLM iMonitors and their reporting, and then the back end, some of us that are network leaders have been allowed to be super users, so that we can be able to see how this is being done. However, my question comes in with the segregating data, especially at community level, much as we don't want to do it in a silos way. How do we ensure that when we are coming up with data, and so that we can be able to back up the request that we'll be making at the GC8 development? How do we ensure that we can be able to justify the data that's been collected to support what exactly we are requesting? And third and not least,
the final one, please.
The final one, I really want to commend AMREF for having come up with an alternative. I would say, is it an app? We've talked about a telephone booth or something like that. Maybe we need to be told a little bit more of how it works, but at least if you cannot be able to download the app and be able to report the same, if you can be able to use the WhatsApp. So it's key that also the stakeholders get to understand how it works, so that we can be able to share the same information with our communities. Thank you so much, and kudos to the good job.
Thank you so much. And I want to request the team, the participants, your indulgence. I want to request for just 5 more minutes after the hour, so that all the questions are responded to. Next, just for karaoke. Oh, no, sorry, Christabel or Duo.
Yeah,
then
it was me.
Okay.
Hello.
Who is that?
This is Jakateng.
Who is this?
It's
Otina
Otina.
Kennedy.
Yes, he's Bill.
Kennedy.
Yeah.
Okay. Take it up.
So who is going? Is it me?
Kennedy. Go ahead.
Okay, thank you. First of all, I want to thank the presenters for the wonderful presentation and the chair for bringing out the CLM component and also the work that has been done by AMREF. One thing that I keep on asking is that specifically TB is very gendered in terms of the way it impacts communities, and more men are affected by TB comparatively. There's a research that was done by RESOC together with the Light Consortium, and it is becoming increasingly evident that men are still missing in the response, in the gendered response for TB. I don't know to what extent have we been able to incorporate concerns or issues that are specific to men, so that the CLM is able to unearth some of the issues. I know there's a mention of issues around alcoholism and alcohol substance abuse, which is also men dominated. But then beyond that, what else have we incorporated in the CLM to ensure that men and boys are mainstreamed in the response and in the CLM activities? Thank you very much.
Thank you so much, Christabel, and then Josephat, and then we close that chapter. Christabel?
Good afternoon, everyone. My appreciation goes to the presenter. That was very informative, and also to appreciate the much work that has been done. My concern goes to James. We have in other counties that the super users are unable to actually log into the iMonitor because the credentials one is not working. So how can AMREF support so that they can be able to use the iMonitor tool? Again, another clarity that I needed. You mentioned some of the CLM tools, but I'm also wondering if the client exit interviews can be called CLM tools, because you've seen in some instances whereby they are being used and that they are actually working, but it was not mentioned as one of the tools. Over to you.
Okay.
Thank you, Eva.
Thank you so much, Josephat Karaoke. You have the floor.
Thank you so much. And for me, just to appreciate the insightful session that we've had. As a peer monitor, I can really tell we are working on something that is really achievable. So my question is really about in terms of capacity building and setting of the CLM iMonitor data. As I mentioned earlier, some of us are really worked on the ground, and we have seen what has really worked. And we have already, shared with the paperwork with other, places like conferences and all that. But the problem is you're lacking support to attend these conferences to showcase our work. So I don't know, how is the leadership able to, help us in terms of resource mobilization and able to, for us to showcase that we have worked out there. Also, another question is, in terms of recommendation, we have recommended that, yes, as much as we are doing sensitization on the ground, but some of the communities have not been reached. We recommended that some of the sensitization can be done through, online platforms such as TVs and radio. So I don't know where in terms of AMREF and other partners, where are we in terms of that? Yeah, thank you so much.
Okay, thank you so much. I want to hand it over to James and Philip to respond to the questions, and also Brenda in a very few minutes. Thank you.
Yeah, I will also add Chair.
Yeah, and Christine as well.
Can I go ahead?
Yes, James.
Yeah, so I will respond to some, and Christine will also respond to some. So to start with the last question from Josephat regarding support, maybe to attend conferences to show the work they have done. And I think sometimes back we did receive the request from Josephat, if I'm not wrong, for a paper that had been accepted. So the challenge that we have, as some of us might be aware, that there was a reprioritization that took place last year, and the funds that were allocated for support of communities to attend conferences were reprioritized. So when we were doing the writing of GC7, the thought was there and it was actually allocated the funds, but we know what is taking place in the donor landscape. The funds were reprioritized. So that's where we had the challenge. In the previous grants, we've had, and a number of community members who had something to present have been supported to attend conferences, including the Union Lung conferences, the annual one. Then non-working credentials. The credentials, the major reason why some of them might not be working, we did activate for all the super users, but we've noted a bit of a challenge with forgetting these passwords. The system is very sensitive. If you put a password 3 times that is wrong, then you are definitely blocked. So in such instances, the SR have always been reaching out to us and they are reactivated. So it is just a security issue or a security check that has been put in the system. If you put the password 3 times that is wrong, you automatically get blocked. But we've always tried to address this issue on case-by-case basis. SRs have already reached out, and we've promptly supported to unblock them. So the other issue I want to talk about, there's somebody who mentioned iMonitor is not working in Migori. I'm not very sure if that is the case, because I've just checked even today, there are issues that have been raised from Migori. We understand we had a bit of an issue with some phone model, which we are trying to resolve. So I know some times back, some people were not able to use the app. There were some mobile devices that the system was rejecting, but we are addressing that. That in the alternative, we gave a web version, a link where they could, an alternative for them to raise the issues, which is working. Then I've also seen a comment from John Kimani from Kenpud, if we could include the arm reduction interventions also in the iMonitor. So maybe I will leave that to Christine. Then some super users are not responding to issues. Yeah, we acknowledge this, and we are trying our best to engage them. Remember, it is more of advocacy that we are doing, and we've even planned some meeting, I think, on Friday. We are planning a meeting on Friday with the implementing partners to brainstorm on how best
Are
we
we
can.
still there?
Yes, Kennedy,
Yes,
unless
yes.
if you are not able to hear me, then yeah, I think those are what I
We can hear you, James, loud and clear.
Yes, I give it to Christine, maybe to respond to any issue that I've not been able to address. Thank you.
Okay, Christine. Thank you. Christine, take it up.
Okay, so if I start with the one for harm reduction, yeah, so there is no harm reduction in TB, basically. That's an intervention within the HIV grant, and that component is there in iMonitor. So with regards to TB, the communities within the among people who use drugs, you are supposed to select from which community you come from. So when you select people who use drugs or inject drugs, and then you come and select the TB module and give out your issues, the issues for that community will be picked. So yeah, because in TB, the bit of harm reduction in terms of intervention is not there like as part of the TB interventions. So maybe you can try that. But if your constituency needs more sensitization, we can always organize, even if it's coming to your existing forums to be able to explain further. Then, so issues around alcoholism in the field. So those are the discussions that need to be done, like the way Brenda has explained. When you are with in that community, after you have seen the issues that are coming through, somebody should be muted. So, so then you are supposed to now discuss those issues of alcoholism and come back and come out with homegrown solutions for that community. The way just Brenda has explained what they are doing in their facility framework, Nyakwana will be able to pick that up, and the bit of having the CLM up and running and listening to these key issues, you will be able to respond to that. So segregation of data. So yeah, data can be analyzed further. There's the public dashboard. I don't know if Rosemary you've been able to see it, where you can see the various segments, but you can also be able to get further analysis. We are also giving credentials to the network leaders so that they can be able to access the super user dashboard that has the Excel sheet where you can get more analysis. So the chatbot, it's an AI innovation. So where you just go to WhatsApp, and once you save that number and you chat hi to it, then it will bring you the questions that are normally in iMonitor, and when you respond, then you'll be reporting to the issues the way you are supposed to. So the chatbot is up and running, and it can be used if you save the number that was in the presentation. So I don't know if there's something I have left, but there was another question here on whether any integration in community health services structure, any data where county departments of health appreciate its impact and utilization. So yes, at the county level, it's the county management teams themselves that were able to also now officially share the facilities where these monitors are attached. We've had scenarios where the CDHs are asking to be taken through the public dashboard, so then they can be able to pick the issues. We've had areas where CECs have allocated money to HIV, TB, malaria based on memos that have been written. We've had areas where there is redistribution of drugs that is coordinated at county level because of issues through iMonitor. So yeah, there are counties where the county teams have been able to adopt the CLM very well, and they are working together with communities, like in Nairobi County, where even there were some what are they called, askaris who were replaced because of not being able to support communities well. So yeah, let me stop it at that. Back to you.
Thank you so much, Christine, for your interventions.
Thank you, Christine.
Philip?
Just say quick ones. And the issue of the alcohol, I think Christine has talked about it, but also as a country, we are also implementing PPM, the public-private mix, where we also try to work with even those informal, those private practitioners to help and reach out. Under the GC7, the current grant, I remember in some innovations under active case finding, where we were also putting strategies to help us reach these people under key population under TB. And one of those outreaches were to target those dens and such kind of things. So I think these are some of the issues we may need to package as we move to GC8, so that we implement. If we can bring out the outcome of some of these innovations, it can help us to maybe put some resources to reach more people. I would also ask that even as champions and actors in the TB space, we also may need to organize ourselves at those lower level and link up partnership and work with the local players to help us also to support some of these. So on the issue that was raised by Kasiba about convening, we have been having some issues, but last week I had some conversation with UNAIDS and some other partners here. So there's possibility that we'll convene before end of this month so that we are able to take stock and know where we are and what is our way forward. So there has been some delays, but before end of this month, we'll convene. Thank you very much.
Okay, thank you so much. I think the other question that was meant for Brenda was the issue of alcohol, and it has been addressed by Christine and Philip. I believe all the questions have been thought that are asked have been well responded to. Unfortunately, we'll not have time to respond to all the questions. There's so many questions in the chat box, but time has really run out. I want to take this opportunity to really thank the about 197 people who have stayed on beyond the time that we had set. This really demonstrates that there is a lot of eagerness to learn about the CLM, and probably should do this more often. I want each one of you to really appreciate yourself for being here with your eagerness to learn. And for the organizers, AMREV, National TB Program, and all the other partners, we really want to appreciate the thought of creating more awareness about CLM. In summary, CLM is not just for complaints, it's for compliments. If you forget anything else, just remember that. And the other one is, it is not just for those ones who are in health, it is for the entire public. So I'm hoping by the time we close this, CLM will have, the iMonitor will have more users than when we started. And just one issue that has been raised on the chat box, people have been trying to log on, but there seems to be a challenge. So I hope the administrators will have to look on into that. With that, thank you so much. We close the meeting. Enjoy the rest of your evening. Bye.
Thank you so much. Bye.
Bye-bye. Thank you.
Bye.
Eric, you can close the meeting.